Another young man sitting here right next to me. This is Mr. L.J. Scott, one of the seniors, and he is with me on the educational rotation, which is something you guys will have a chance to do as well when you get to your final semester if you're interested in pursuing a teaching career in this field. So I'm going to have him actually introduce himself and talk to you guys for just a couple of minutes before we get started. And LJ, the floor is yours. Go ahead.
All right. Well, hey, what's up, you guys? So, like Miss Donahue said, I'm over here on rotation. So, I've met some of y'all already. I mean, you guys seem like a really cool class. Everybody's super friendly. Like, I'm gonna take over pretty soon in a little bit. So, can't wait to do that. Just a little bit of facts about me. So, I actually came from film school. I dropped out and then came to Houston. My mom, she's actually in Harris Health. Like, she'd be walking around the hallways sometimes and stuff. She's the one who told me that I should get into this program and been in it ever since. Just want to let you guys know too, like everything we're about to go over with the C spine, everything you guys got coming up, especially head work, is it's not too crazy, you guys. Like Mr. Donahue makes it super easy, just understand, go through and everything like that. And I'll for sure do my best when I'm teaching to make sure everybody understands it too. Couple quick facts about me too, just in case you guys don't know. Like I always say, I do personal training. Um, I have a lot of tattoos, like a lot. I have my arm, whole entire chest and stomach covered. I'm going to cover up my whole entire back soon. Just basically, if you guys know Wiz Khalifa, the goal is to like get on that level. So almost quite there, not really, but getting there though. But other than that, hey, I can't wait to teach with you guys. Can't wait to meet more of you guys. I mean, you juniors seem awesome. So keep on going. Keep up the good work.
All right, thank you, LJ, and great guy right here. I've known him since the beginning of him starting this program, and he's never disappointed. He just oozes charisma, if you can't tell already. He's actually one of our I leads as well. He's going to be presenting for competition at TSRT for his. You want to tell him what your
Oh, it's
subject
called
is?
Hey Siri, what's my pathology?
Hey Siri, what's my pathology? And it's about COVID and using virtual reality, I believe. Correct?
Yeah, artificial intelligence.
Artificial, that's right, artificial intelligence to
Yeah.
help diagnose COVID on chest X-rays. Very fascinating presentation. So he's gonna be recording that next 2 weeks for competition. So we'll try to make that available to you so you can see what he put together and kind of give some insight into what you guys can expect over the summer for research and doing your papers and presentations, because that'll be here before we know it. Absolutely. But thank you, LJ.
Yeah, for sure.
And like he said, he's going to be teaching your class starting this Friday when we get into positioning. I'll be here as well if we need to clarify anything, but I have no doubt he's going to do a great job. He knows his stuff. He's very talented. And I think you guys are going to enjoy his presentation style. So I'm looking forward to it as well. I'm looking forward to seeing what he does. So don't give him too hard of a time, don't break his poker face like you guys already broke mine. Work with him, ask him questions, ask both of us questions. Like I said, I'll be here as well, and we'll make sure that we get this material delivered to you in the best way possible.
Definitely.
All right, guys. Well, let us go ahead and jump right back into it where we left off. Let me get our presentation pulled up. Not like this chair is sitting in.
It's fighting you over there.
Well, my armrests are not working in this chair, so I'm not going to fool with that anymore. All right, everybody. Let's see. Here we are. Pull up. There we go. Faces back on my other computer here. We got 3 setups here. We got a big screen TV and 2 computers. So no one can hide today at all. We see all and know all. All right, guys, so we left off last time talking about the difference between T-spine and C-spine when it comes to viewing the laterals and the obliques and what corresponding anatomy that we're actually visualizing when we go from lateral to oblique. So one of the answers is right here in front of you, but who here can tell us, talking about C-spine, what specific anatomy do we see specifically on a lateral C-spine and an oblique C-spine? Who would like to give that a shot?
The lateral is the zygapophyseal, and oblique is intervertebral foramina.
Correct. And what would be the T-spine? Well, the answer is right there in front of you on the screen, but what's the T-spine show on both those views? Anybody else, or Jonathan, you want to take it again?
Just the opposite. So left lateral T-spine is intervertebral foramina, and oblique is zygapophyseal.
Correct. And another question, when we talk about those two specific pieces of anatomy, whether we're talking about the intervertebral foramina or the zygapophyseal joints, what is the specific way we must label that anatomy? What did I hammer home to you guys on Monday?
Is it that they're labeled in pairs?
They're always labeled in pairs, exactly right. So for example, if we look down here at this picture, we're on WebEx now, get my drawing tool. If I was going to say what intervertebral foramina is that, if we make the assumption that this is T12, which if you remember, when it comes to a lateral T-spine, the assumption is that last visible vertebrae with the rib hanging off of it will be assumed to be T12. So this intervertebral foramen is going to be the intervertebral foramen of T11 and T12. Please do not just write the intervertebral foramen of T12. That would be incorrect. You'd only get half credit. You must include each pair of vertebrae that specific anatomy is located between. Same concept for the zygapophyseal joints. If I'm labeling a zygapophyseal joint, which we can kind of see one right here, let's count these vertebrae, 12, 11, 10, 9, 8. This would be the zygapophyseal joint of T8 and T9. Excuse my terrible handwriting on there. But it's always going to be in pairs once again. What was that one other piece of anatomy which we can visualize on that x-ray and that model that comes in pairs? What was the other one? Because there was 3.
Intervertebral disc space?
Intervertebral disc space, correct. Intervertebral disc space, which that would be right here. So if I ask you to label that anatomy, 12, 11, 10, 9, that's the intervertebral disc space of T9 and T10. So I know I've said it a lot. I've been repeating it over and over again, but please make sure that anatomy is always labeled in pairs. Otherwise, you will not get full credit on that. So this is just an example here of those zygapophyseal joints on the T-spine. If you remember, like we just said, when we're, half credit, but you want to go for more than half credit. Don't be claiming half credit. You want full credit. Don't do that to yourself. So zygapophyseal joints will only be visualized clearest when we talk about that LPO, RPO, REO, LEO, oblique T-spine specifically. Now, who remembers, what was that angulation on those oblique T-spines? It was a very sharp angulation. What was that number? About 70, 75, correct, 70, 75 degrees. So very, very sharp oblique. In fact, it's almost a lateral. It's just not quite a lateral, and we got to put it in that sharp angulation of that body. Otherwise, those zygapophyseal joints aren't going to pop out how we want them to see. They'll be actually superimposed and covered up and not in the best view. We want them nice and distinctly separated so we can see that superior articular process meeting that inferior articular process coming together to formulate each of those zygapophyseal joints. So what are we looking at right here? Based on what we just talked about, this image on the left, if I just showed you this image without any context, based on the anatomy we can visualize, what position is that patient in? So I got someone saying lateral C-spine.
Oblique.
So it's actually going to be an oblique C-spine. How do we know that? So remember, for the C-spine, the oblique position will demonstrate these intervertebral foramina the most clear. The zygapophyseal joints will only be visualized on the lateral. So we know just in context by the fact that these intervertebral foramina are so clearly defined that this is an oblique C-spine. Now, as far as the REO, LPO, RPO, LEO, same concept with bony thorax, guys. I only expect you to put, like if I give you an image like this, you just need to put this as a right oblique C-spine. You don't need the REO, LEO, LPO, so on and so forth, unless it's actually labeled on the radiograph, which some texts will actually label that they did RPO or REO on the radiograph. But as far as labeling for me, because they're very, very similar in retrospect, as long as you put an oblique C-spine, I consider that acceptable. But do keep in mind, once again, we're going to see those intervertebral foramina most clear when we're visualizing an oblique C-spine. This would be an example of the opposite side, same concept. Once again, what do we see? Very beautiful, clear circular patterns labeling those intervertebral foramina between each of those separate C-spine disc spaces. Now, because I can see each of those foramina so open and clear, I know that this is an oblique C-spine, and specifically, it's a left oblique C-spine. So start training your eyes to look for that specific anatomy between C-spine and T-spine, and do keep in mind that they're inverse of each other. Because for T-spine, it's going to be laterals that show the intervertebral foramina, and then the obliques show the zygapophyseal joints. C-spine, obliques show intervertebral foramina, laterals show zygapophyseal joints. Now, I think it was Jessley who said that she just loved positioning herself in that oblique C-spine today. It was just so comfy and comfortable. She was telling me all about it today. That was her favorite position. Is that accurate?
No, Mr. Donahue, my favorite are the ones where we get to lay down. Those are my favorite.
I can echo that. Yeah, you get real comfortable on that stretcher. I agree. Okay, so here is what we just talked about on a nice, beautiful chart for you in case you're still having some trouble knowing what anatomy is shown. Know this concept right here. I keep repeating it for a reason because I'm going to ask you questions on it, and your registry will love to ask you questions on this as well, because when it comes to spinal x-rays, they want to make sure you know what you're specifically visualizing between these two views. So once again, for the intervertebral foramina, when we're talking C-spine, it's going to be an oblique, but specifically, it's going to be a 45-degree oblique. So for the thoracic spine, if we want to see the intervertebral foramina, we're going to be putting that patient in a true lateral position. And then look, it's going to go opposite when we talk about zygapophyseal joints. For cervical spine, when they're in the lateral position, we're going to best visualize the zygapophyseal joints. And for thoracic, we're going to visualize those zygapophyseal joints in that 70-degree oblique, that very, very sharp oblique, 70 to 75 approximately. Now you'll see the word upside on each of those for posterior obliques. Now you can do anterior obliques, but the most common method for doing these obliques, whether it's C-spine or T-spine, is going to be the posterior obliques. Can anybody tell me why you think that would be the preferred method when it comes to obliques? Based on the concept of obliques, why would we choose posterior obliques as opposed to anterior, preferably? Does anybody know? Very good, because the spine will be closer to the IR. Closer to the IR. And where's the spine located? It's on your posterior surface of your body. Therefore, it would be preferable to always do the posterior obliques, which is going to put that spine closest to the IR. Now you'll also see the word upside. What does that mean? That means that we're going to visualize the intervertebral foramina on that oblique C-spine on the elevated side. So if I'm doing an RPO, I am visualizing the left intervertebral foramina. If I am doing an LPO of the thoracic spine, I am visualizing the right zygapophyseal joints because it's visualizing the upside on both of those specific obliques. So for posterior obliques, we visualize that specific anatomy we're talking about on the elevated or up sides of those positions. Then for laterals, it's going to be whatever side's closest to the IR. So if I'm looking at the zygapophyseal joints in the lateral C-spine, if I'm doing a left lateral, I'm visualizing the left zygapophyseal joints. If I'm doing a thoracic spine lateral, I'm visualizing the left intervertebral foramina. So for obliques, it's the upside. For the laterals, it's that corresponding lateral side that's closest to the IR. Some more important concepts to make sure you remember on that anatomy specifically. That makes sense, or we need to go back over that? We're good? All right. So now we're going to talk a little bit about a few topographic landmarks, usually everyone's favorite thing. I'm so sorry to disappoint you, but yes, we do have some more topographic landmarks that we have to make sure we know where each of those pieces of anatomy lines up with each corresponding vertebrae. There's not too many to go over this time. Don't worry, some of it's stuff that we've already seen before. So we're going to start at the very top, a very important landmark that we need to make sure we know from here on out, because this is really going to play a large part in the headwork chapter. That's what we call the EAM. Now, some of you heard that in lab today, because I was spying and listening to what you guys were learning about. What does the EAM stand for, based on what Mr. Fong told you? He may have told you guys on Monday as well. What does that stand for? Anybody remember?
External auditory meatus.
Very good. The external auditory meatus. Basically, that's referring to your ear canal, your ear hole, where your eardrum is. Very important landmark to not forget, because when we talk about the topographic landmarks on the face, every single one of those positioning lines on the face lines up with that EAM. So we're going to come back to that full force in the head work chapter. We do use it a little bit on the spine work, and we'll talk about that in the positioning area. So of course we have C1 all the way through C7. But what's going to line up with these vertebrae specifically? Well, first we're going to have what's called a mastoid tip. Now, what in the world is a mastoid tip? Well, if you feel behind your ears, there is a little indentation under your ear. It feels like a bump, kind of. You know what? Y'all know what I'm talking about? If you can see me on the screen where I'm pointing to, right here, that is your mastoid tip. That's an important topographic landmark when it comes to a lot of positioning of the neck, the C-spine, and of course the head. That mastoid tip falls along the line of C1. It lines up with C1. The mastoid tip will line up with C1 specifically. What's the next big one? We have what's called the gonion. I talked a little bit about that when we were going over anatomy on Monday. The gonion are the areas of your jaw that come to a point where I'm pointing to on my jaw right here. You can palpate yourself. That is your gonion. It's not gunions. It kind of looks like an onion with a G on it, but it's actually gonion. That lines up with C3 specifically. The gonion of the mandible lines up with C3. How about that thyroid cartilage? Thyroid cartilage being a very important protection feature of the thyroid itself. The thyroid cartilage is going to line up with C5 and C6 specifically. So there's a little overlap on that one. C5 and C6. And of course, vertebral prominence being a fancy way of saying C7. That's pointing to that on that picture right there for you. So this picture here is just showing you the same landmarks. If we took away the cartoon diagram on the left, E is referring to the EAM, D is pointing to approximately where that mastoid tip is located, C being the gonion of the mandible, B being the thyroid cartilage, and A being the vertebral prominence, or C7. So all of these are going to be some important landmarks that we're going to use when it comes to positioning, not only the neck, but also the head work, which is coming really soon. Remember that EAM, that's a big one right there. That EAM is one of those huge topographic landmarks. It's not going to go away. That could equal a lot of registry questions. There's a lot of stuff that goes on with that EAM. Put a big star on that EAM and do not forget it, because every positioning line we talked about on head work directly corresponds with that external auditory meatus. And here's a few more. We talk about the T-spine. So we start at the very top, vertebral prominence. That's another way of saying C7 once again. That's showing you that division line of where T1 approximately falls. But as we move down, we've talked about a few of these before, especially in the bony thorax chapter. If you remember, the jugular notch is going to line up with T3. The sternal angle is going to line up with T5, manubrium T4. The body of the sternum is going to line up with T5 and 6. What we call mid-thorax is going to fall between T6 and T7. That's the mid-lung field when you hear about mid-thorax, halfway through the T-spine, between 6 and 7. And that's an easy way to remember that. What's half of 12? 6. So in between 6 and 7 would be our mid-thorax or the mid-lung field. Then that xiphoid tip is going to fall at approximately T11. T11. So some more important topographic landmarks. A lot of these we've already talked about, but make sure you do remember how they correspond with each of those T vertebrae when we're lining them up along the axis of the body. Don't have to worry about these 1.5 inches, 2 inches, or 3 to 4 inches. That's irrelevant. But I do want you to know, if I was to ask you where is the manubrium located, it's approximately located at the level of T4. Where's the body of the sternum? Approximately the level of T5 and T6. Where is the mid-thorax? Approximately T6 and T7, and so on and so forth. Know those topographic landmarks. And that's some of those same topographic landmarks if we're just going to look at it on the body of a subject right here. A being that jugular notch, B being the manubrium, C being the body of the sternum, and D being the xiphoid process. And these little lines down here would be that lower margin of the rib cage, which we use for positioning as well. By the way, make sure you can label these topographic landmarks. If I gave you a diagram of a person, their chest, and I had it exactly as you see labeled here, A, B, C, D, make sure you can identify what each of those topographic landmarks are that's pointing to. Jugular notch, manubrium, body of sternum, and xiphoid process of sternum. Now let's look at a few of these landmarks or positioning lines of the face and the head. Now we're not going to spend a ton of time on this. This will come back full force in 2 more chapters when we do head work, but we are going to name a few of the more important ones that are actually more than you see listed here. Some of the most important ones that we need to go ahead and start contributing to our memory, because we do use a few of these when it comes to positioning on the C-spine, so we got to know where they're located. So when we start from the very top of this face here, the area in between your eyebrows, touch right here, this area between your eyebrows, it feels like a little bump. That's what we call the glabella. The glabella. That is not a positioning line, but it's actually a landmark on the face. Very important landmark. Now, as we move downward towards the chin, we're going to come across our first positioning line of what we call the interpupillary line. The interpupillary line is a line that goes straight through the pupils of your eye, left to right, horizontally. If you looked at my face and I drew a line going through my pupils, that's my interpupillary line. That's something I want to always be very straight when I'm positioning for head work. That's not going to make a lot of sense now, but as we move to head work, that will start making more sense, because as I tilt my head, my interpupillary line would not be going through both my pupils. If I have my head nice and straight, if I put a line going left and right, my interpupillary line will go through both pupils of my eye, which means my head is nice and straight. Now we have 2 pieces of anatomy when it comes to the eyes. If you touch right here and on the inward corners of your eyes is what we call the inner canthus. On the outer edges of our eye is what we call the outer canthus. 2 more landmarks that we need to know about: inner canthus and outer canthus. Then, if you have bags under your eyes, like I often do when I don't get sleep, that area where those bags of your eyes are formed, or if you palpate under your eyes, you can kind of feel the bottom of your orbits, where your eye hole is. That's what we call the infraorbital margin, IOML, infraorbital margin. Very important positioning line when it comes to positioning for skull and some C-spine x-rays. Now, I want you to palpate on the top of your nose. Some people have a little bump right here. I have a little bump on the top of my nose. That's what we call our nasion. Top of the nose is the nasion. Essentially, that's where your nasal bone begins when it's protruding off of the skull, the nasion. Now, if we go below our nose, more inferior, the area right above your lips and right below your nose, right here where I'm pointing, is what we call the acanthion. Very important one to remember, the acanthion. And then the final 2 on this AP picture of a face would be the angle of the mandible, which is that gonion, and the mental point, which is the very, very point of your chin, mental point. So these are some major landmarks that we're going to use when it comes to positioning the head and neck in particular positions on this chapter, and also when we get to head work. Now, when I go to the next picture, we're actually going to see a lot of these lines from a side view and a lateral view. And we'll show you why they're so important here in a second. Looking at these lines right here, the idea with each of these positioning lines is I want to make a certain positioning line perpendicular to position the head correctly. So if I had a position that called for my IOML, which is the infraorbital meatal line, to be horizontal and straight, I would want to tilt the head downward until this IOML is a nice, straight, beautiful horizontal line. If I had a position that called for the OML to be perpendicular, I would want to tilt the head down even further so that my OML line is in a nice horizontal straight shape. Now, one thing you'll learn to do in lab is you're going to take your pencils out. I don't have a pencil with me. Here we go. You're going to take your pencil out and line it up with each corresponding line. As I move my head up and down, that pencil is going to represent the line that I'm talking about. So if I'm talking about the IOML, which you see on that picture, you see from a side profile. If I have my head pointed up, my IOML is not perpendicular. As I dip my head down, bring my chin down, I'm going to dip it down until this is a nice, straight, beautiful horizontal line. That's going to tell me that my head is in the correct position because my IOML is perpendicular to my IR of what I want to visualize. So that's why we use those positioning lines. Whatever the line is that's called for on that corresponding position, I want that particular line to be on a nice, horizontal, perpendicular line. So I'm going to tilt my head up and down depending on what I'm looking for. If it calls for the AML, which would be the acanthomeatal line, that's the area right beneath the nose, I'm going to put my pencil at my EAM. You always start at the EAM, by the way. I'm going to make sure the tip of this is coming out of the acanthion. That's my AML. So if my AML needs to be perpendicular, I'm going to bring my chin up until that line is nice and horizontal. Now my AML is what I call perpendicular to the IR. So you're going to learn a lot more about that in lab. A little bit difficult to demonstrate here on the webcam, but in lab, when Mr. Fong's talking about these positioning lines, that's what we're making perpendicular to the IR for each corresponding position. So it may be the OML, the IOML, the AML, or the MML. There's actually more than that, but the main ones we want to focus on right here that I want you to go ahead and put stars on and highlight are the OML, the IOML, the AML, and the MML. That's the ones we're going to start talking about the most right now. That's the most commonly used. And of course, the EAM, because depending on what line that you've got to use for that position, it's always going to terminate at the EAM or start depending on how you look at it. Now that seems really confusing right now. I can see your faces, but it's going to make a lot more sense on the headwork chapter. We use a little bit of this on C-spine, and Mr. Fong will break that down for you when you position in class. But the ones I want you to go ahead and memorize, if I was to give you a diagram, is the OML, IOML, AML, and the MML. It's the four main ones to remember. And of course, the EAM. That's its own separate area. So know how to label those on a diagram. And pay close attention in lab because he's going to show you how to position for those in person, which will make a lot more sense when you can actually demonstrate it on the IR. But your pencil is your best friend, guys. And I did tell you guys to go ahead and purchase a styrofoam head. If you have already purchased your styrofoam head, you can start adding these lines on there with a piece of yarn. I'm going to show you how to do that as a class when we get to headwork. It's going to be an excellent tool to help you memorize these and something you can actually use at home to position for this different headwork yourself. You can actually practice at home. Works great. We on board still? We good? All right. Make sure you're not glazing over too bad there. Okay. All right, so we looked at this picture a couple of slides ago. If I asked you to tell me what is E pointing to, what would you tell me? The EAM, correct, which stands for what?
External auditory meatus.
Very good. External auditory meatus. Make sure you know both names, both terminologies. How about the letter D? What are we looking at? It's that area behind your ear that you can palpate. Like a little bump. Mastoid tip. Very good. The mastoid tip. And just for fun, I know we're not there yet, but does anybody know what cranial bone the mastoid tip is located on? Let's jump ahead 2 chapters. I just want to see if anybody knew it.
Occipital? Or I'm just guessing.
Not occipital, but you're close. What's in front of the occipital? It's not going to be the orbital. I'll tell you this, it starts with a T. Man, that's a good tempo.
Temporal one?
I can hear that tempo.
Temporal?
There you go, the temporal bone. The temporal bone. Easy way to remember temporal bone, it's where your ear canal is located. That's how you hear the tempo. The temporal bone has great tempo. Everyone's going to get temporal bone on the cranial chapter now. There you go. All right, how about C? What is C referring to? That's that area on the mandible. The gonion, very good. Please don't say gunion, by the way. I always get someone that gets smart and says gunion. It's gonion. I know it looks like an onion, but it's gonion. Now you're going to say gunion just to mess with me, huh? Justly, I can see it all over your face. Yep. How about B? How about B? What is B referring to? The thyroid cartilage. Very good. And what about A? Probably one of the most important ones that we're learning this chapter. C7, also called what, guys?
Vertebral prominence.
Vertebral prominence. Very good. All right, let's do a couple quiz questions here. Let's see where we're at before we move on to pathology. That's all the anatomy, by the way, for this chapter. Everyone say, oh, thank God, hallelujah. No more anatomy. Yes, whew, feels good. I promise next chapter doesn't have near as much, but head work is going to be, we're just not going to talk about head work yet. I think Jonathan got a bit of a preview of that today. I was showing him some of the bones. But let me go ahead and give you a few quiz questions here. Let's see where we're at. Does anybody else like Gollum, Smeagol? I mean, he's like one of the best characters in Lord of the Rings. You know, I had to put his picture on there. Yes. I only have like 2 Lord of the Rings fans out there. That's okay. That's okay. You're missing out on some great stuff, let me tell you. Daniel knows what I'm talking about. Yes, my precious. Yes. All right. The tapered end of the solid spinal cord is termed what? That's referring to the area where that spinal cord ends, by the way. Okay, the conus medullaris. That is correct, the conus medullaris. Now be careful with that, guys, because I made this mistake when I was in school. I put the choice on there on purpose of answer C, where it says spinalis terminalis, because the word terminate typically means the end of something. That's actually not the end of the spinal cord. So don't pick C, it's actually the conus medullaris. Don't mix that up with that term on letter C there. Easy mistake to make. Same with filum terminal. That's another mistake people can make. It's actually the conus medullaris. It's the tapered end of that solid spinal cord.
Does it continue on though, the spinal cord, like just not the where it's solid, it's kind of just like stringy, right? Isn't that how it works?
Well, there are some nerves that come off the end and go through the lower parts of the body, but that's more on the nerve. That's more just some specific nerves, not the actual solid spinal cord.
Okay,
Actually,
I remember the
solid
caudal
spinal
echina. That's why I was.
Now, you're probably thinking of all the nerves that come off the end on the bottom. There are a lot of nerves that come off the end of it, but the actual end of the solid spinal cord within the vertebrae is going to be the conus medullaris.
Okay.
Good question, by the way. Very good question. Let's move on. What is the total number of bones in the adult vertebral column? The adult vertebral column. Let's see. A. It's actually 28. 28 in the adults. Now put those 2 numbers there on purpose because they're very close. Easy mistake to make, but make sure you know it is 28 for the adult, 33 for the child. 33 for the child. Close enough. Close enough. Hey, you know, I know you can say that, but it's not going to be close enough on the registry. Remember, that one question can keep you from passing the registry. Never go with the attitude of close enough.
Wait, you're saying it's 28?
Mr. Donahue, on the notes you told us it was 26.
Isn't it 7, 12, 5, and then sacrum and coccyx?
Did I?
7, 12, 7 plus 12 is 19, plus 5 is 24.
Let me double check myself.
Okay.
I misspoke. Let me double check myself. Nope, you're right. It's 26. I marked the wrong answer. Look at that. I made a mistake. That's all right. I make mistakes too. Thank you for the correction. I am sorry about that. I will fix that on my PowerPoint. Yeah, it should be 26. So sorry. You know, I said I'm not a numbers guy. I'm telling you, I'm not a numbers guy. I'm a words guy. That is the truth. That is the 100% truth. Okay, the thoracic spinal curvature is classified as a primary curve. True or false? It's back to the beginning of our PowerPoint. See, A, true, 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 true. And it is indeed true. Yes, the primary curve of that thoracic spinal curvature. And does that spinal curvature protrude anteriorly or posteriorly? Posteriorly, you are correct. Very good. Very good. Okay, an abnormally increased swayback spinal curvature is termed what? Swayback being the key word there.
Lordosis?
That's your answers here. See a majority B, and it is indeed B. That's going to be lordosis. Lordosis. Talking about that lordotic area, the lumbar area, where it dips anteriorly, causing that sway back condition if someone has a severe deformity of that lower back protruding anteriorly. The intervertebral joints are classified as what? Arthrodial, B, 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 B. They are actually amphiarthrodial. Amphiarthrodial. I know we actually did not talk about that. I threw that in last minute because I forgot to add a slide on what kind of joints those are. Make sure you put in your notes that the intervertebral joints are classified as amphiarthrodial joints. Amphiarthrodial joints. Not too many joints to have to worry about this chapter, thankfully.
Mr. Donahue, review moment. So are there any joints in the spine that are diarthrodial? Is it?
Are there
Anybody?
any in the spine that are diarthrodial?
Yeah.
There are some up towards the superior, like the C1, C2 area are going to be more so diarthrodial. As far as what you need to know for your notes, you just focus on the majority of the spine. The majority of the spine and the intervertebral joints specifically are going to be the amphiarthrodial classification. But yes, to be specific, there are a couple of diarthrodial being around the C1, C2 area.
Nice, thanks.
Focus on amphiarthrodial. That's going to be the majority of your spine, intervertebral joints specifically. The soft, semi-gelatinous inner part of the intervertebral disc is termed what? I knew I was going to put that one on there, huh? That's one of my favorite words. That being the nucleus pulposus. But let me ask you this. What is the annulus fibrosus? Because that's a part of it as well. Correct. That's what's going to surround the nucleus pulposus. Make sure you know both. The outer protective layer. Very good. Very good. Nuclear core, that's made up, and fovea centralis, that's made up as well. The articulations between C1 and the occipital condyles of the skull are termed what? What do you think that is? That's something else that I did not mention earlier in the notes, but it's something I need to add because it actually is something very important. Since we'll say occipital facets, this is actually a specific joint. That's your clue. I'm seeing C question mark, C, and it is the atlanto-occipital joint. So how do you remember that? This is a very specific joint when it comes to C1 connecting to the base of the skull. So what is C1 also called? The atlas. What is the base of the skull called? The occipital bone. Therefore, the connection between C1 and the occipital bone would be the atlanto-occipital joints. This statement right here is the only thing I need you to know about that specific joint. You don't need to actually point it out on an X-ray because it's almost invisible to see on the views we do. But do know if I gave you a textual question asking what is the articulation between C1 and occipital bone, I'm sorry, occipital condyles of the skull, that's going to be the atlanto-occipital joints. Atlanto-occipital joints. It's going to connect C1 to the base of the skull, the occipital bone specifically. All right, the costotransverse joint. We talked about this last chapter as well. That's formed between the what? Seeing some D's. See lots of D's. Good. It is D, the tubercle of the rib and the transverse process of the vertebrae. Very good. That costotransverse joint. What's the other joint we talked about in that area? The costovertebral. Very good. And where's the costovertebral joint hook up on the spine? Where's that connection point? Head of the rib to the body of the vertebrae. Very good. Nice. Very good. All right, let us move on to pathology. Not too much to go over on pathology, but some interesting things we're going to look at here really quickly. See how we're doing on time. Good. All right, so we have a few what we call most common types of fractures that occur in the spinal area. That being what you see on this picture right here. So the first one's going to be what we call a subtype A1 fracture of the spine. That's going to be specifically also a wedge or impaction fracture. If someone fell and the body became compressed or cracked due to pressure, that's what we mean by a wedge or impaction fracture, also known as subtype A1. If the body of a vertebrae splits into two pieces along the middle, it's going to be what we call a subtype A2. That's a splint or pincer type impaction fracture, like you see in the X-ray, I'm sorry, the diagram right here. It's actually splitting that vertebrae into two separate pieces. Subtype A2. Now, subtype A3, that's going to be a more severe type fracture where the entirety of the body of that vertebrae is fractured into multiple pieces. And also it involves what we call posterior wall involvement. Essentially, it's referring to the posterior end of the body of that vertebrae becoming fractured and falling into the more posterior areas of the vertebrae. And also if the lamina itself, which we see right here, the lamina itself is fractured. A little hard to see, that picture's a little small, but it's going to be the entirety of that body fractured into multiple pieces, with that lamina also being fractured towards the posterior ends. Now, subtype A4 is very similar to subtype A3, but if you look at these side by side, when we talk about subtype A3, we have this crumbling of the superior area of the vertebrae, but the inferior area is still intact. For subtype A4, that's what we call a complete burst fracture. The entire body of that vertebrae is split into multiple fragments, with also sometimes the lamina being fractured as well, which you see right here. So how do you tell the difference? Well, incomplete versus complete. An incomplete burst fracture, also known as subtype A3, only is going to have fragments on half of that body of that vertebrae. Whereas subtype A4, being a complete burst fracture, the entire body of that vertebrae is fractured into multiple pieces. If you look up side by side, it's really easy to see a difference there. One's incomplete versus one being a complete burst fracture, crumbling into multiple pieces. These are your four most common types of fractures in the spine, by the way. We're going to see a few more. So move on here. The more obscure types of pathologies, but sometimes you'll see them in clinic as well. One in particular that's quite fascinating. So right here, this is showing how they actually go about fixing some of these fractures we talked about. This would be an example of a complete burst fracture because every portion of this vertebral body is fractured. A little hard to see on the X-ray, but all the body is fractured into multiple fragments. They're actually going to go in and put in a device here to hold those fragments together and help stabilize that neck with these screws and these plates they'll actually use to repair these vertebrae. And some of you may have relatives that have these in their body still. And typically, they leave these devices in people's spine for the rest of their life. They're going to have these devices holding that neck, back, whatever area's been fractured together, keeping it from developing worse fractures and or permanent injury if that spinal cord was to be punctured by one of those fragments of that bone. Right here would be a very, very small fracture, which you see right here on the tip of the corner of the body of that C2 right here. Little bitty fracture, but they would still need to go in with those plates and repair that because that fragment could cause not only a lot of pain, but destabilization of the neck and possible further injury to the spinal cord itself. By the way, let me go back a second. When it comes to these, I want you to identify these via diagram. Don't worry about identifying those via X-ray. For these particular fractures right here, focus on those pictures. Now this one right here, I may show you an actual X-ray or diagram, but this is a very uncommon type of fracture that occurs that we call Hangman's fracture. Hangman's fracture. Hangman's fracture is a complete separation of the pedicle from the spinous process of that whatever corresponding vertebrae that is. And you can see right here on the X-ray, the body The pedicle is completely detached from the spinous process. Right here is a diagram showing what that looks like a little bit closer. There's the body of C2, there's the dens. This fracture actually completely separates the pedicle from the spinous process. And as you can imagine, why would that be so dangerous? Well, think of where your spinal cord is located. Your spinal cord is running right through here. If those separated pieces were to compress or get moved around, you could actually cut your spinal cord or completely paralyze or kill somebody. Very, very serious fracture that we'll see come in every once in a while. Now, does anybody know why that's called a hangman's fracture? Why do you think it's labeled as such?
If you get hung, that's what the rope snaps.
Most commonly, when someone is hung in a noose, that's the actual vertebrae that fractures the most, killing the person, making them suffocate as well. That C2 specifically, it'll actually fracture like you see in the picture right there. A lot of people that are suicide victims, they try to commit suicide, they'll come in presenting with that exact fracture because that's that snapping you hear when someone gets their neck snapped on a noose. It's C2 being fractured. It's that separation of the C2 pedicle from the spinous process. That's why it's called the hangman's fracture. Now, this is what we call a subluxation type of fracture. That's where the body of the vertebrae is being shifted up into the one above it or below it. This would be what we call a subluxation. Very common fracture that we see quite a bit. Usually when people fall the wrong way, a lot of people fall off trampolines, get in car wrecks, it'll compress those vertebrae together, they'll shift. And once again, if you can imagine where the spinal cord is located, that can be extraordinarily dangerous because you can actually cut that spinal cord or sever it if that vertebrae shifts the wrong way. So that's a posterior or anterior shifting of the vertebrae into another corresponding vertebrae. We call it subluxation. And there's one more, or there's a couple more, but there's a really cool one I'll show you here at the end, which is my favorite, not because I think it's cool. Well, I gotta watch what I say. I don't want to sound like a very terrible person, but I've seen the fracture present a few times and it just fascinated me just because I've never heard of it before, but I'm saving that one for last. If you work in X-ray for a few years, that stuff starts to fascinate you more and more. You'll know what I mean. Now this right here, let me ask you, who can identify the fracture in that image? We have a very specific fracture in that image. It's very critical.
Is it the dents that's fractured?
It is the dens. If you can't see it, here we go right here. The dens is fractured right here. Thankfully, it's not fractured all the way through, so it hasn't split the dens completely off of the axis. But regardless, that could develop into a further fracture. And if you guys remember, the dens is what's linking C2 to C1. If that becomes fractured, you could actually detach C2 from C1. It obviously cause not only a lot of pain, but a lot of danger to that patient's neck and spinal cord. So that's why we do that open mouth view when we're doing a routine C-spine X-ray series, because it's such a critical piece of anatomy that can be fractured, and that's the last thing we actually want to be fractured is that dens, because once again, X is that key, locking that neck together, locking that spine together, and if it was to become fractured, it could actually cause the whole spinal column to become detached, unlevel, further injuring the patient, and or causing paralysis or death if the spinal cord were to be severed in the process. Let me ask you this. I know we haven't went over evaluation criteria, but is that a acceptable open mouth X-ray? Yes or no? So Daniel's saying no. Any other opinions? Y'all think it's good? Science is saying no. All right, the correct answer is no. Why is that not acceptable?
It's a Dantoid. It's a superimposed the top of the tooth.
Correct. If you look here, the teeth are actually obscuring the odontoid tip, and the base of the skull is obscuring the odontoid tip. That's why when it comes to positioning this open mouth X-ray, positioning is very vital. But at the same time, if you get those patients with the big teeth, that can really mess up what you're doing. That's why you go ahead and do the wonderful Fuchs view. You go off Fuchs, those teeth got in the way. Got to do my Fuchs view. Fuchs is going to be your best friend. Now, do keep in mind when it comes to the Fuchs view, we only do that Fuchs view to better visualize the odontoid tip. We visualize the actual joint space, that zygapophyseal joint that we see there, best on this view. So we'd only do the Fuchs view to better visualize the odontoid tip. if it were obscured by the patient's teeth or base of their skull. And last but not least, here's my favorite one right here. It's the one I couldn't wait to show you. I've seen this twice in my career on 2 different children at Texas Children's Hospital. But let me ask you guys, what do you think is going on there? I mean, it's kind of obvious something major is going on, but what do you think this is specifically? Anybody want to share with the class?
Is this that internal decapitation you talked about?
Very good, Jonathan. Very good. That's what we call an internal decapitation. Now, what's decapitation mean? That's a severing of the head from the body. An internal decapitation is a complete severing of the spine from the skull internally inside the neck. So obviously, it goes without saying, if this happened to you or someone you knew, you would have to immediately get this person to a hospital because there's nothing holding the head to the spine at all. It's just floating around, jiggling around. And once again, think about what anatomy is located in that spine, the spinal cord. This could completely snap the spinal cord in two, killing, paralyzing, completely messing that person's life up for the rest of their life. So this is also a great case study, not only of this pathology, but the other ones we talked about, how you've been told over and over again by me, I'm sure Mr. Fong's mentioned it, you should never, ever, ever move a spinal injury patient by yourself. Because if they have not gotten any imaging done, let's say, for example, you were trying to stand somebody up or move them by yourself, and they had this pathology right here and hadn't had any imaging done yet. Well, what's going to happen? Their head's going to flop around, their spinal cord's going to get injured, and guess what? You're probably going to be looking for a job in another country because you probably won't get a job here for the rest of your life. You should never, ever, ever move a spinal patient by yourself because you just don't know what's going on. And every spinal injury should be treated as if it's the worst case scenario. Like this would be one of the worst case scenarios right here because you just don't know until you have that imaging and until they're cleared from that C collar. So be very, very careful when you do spine patients. Not to scare you, but to help you make sure you keep your job secure. And I don't care if you got to go down halfway across the hospital and ask for help. Always ask for help. Don't ever do it by yourself. So another way that this might be classified is sometimes it's called the atlanto-occipital dislocation. Not exactly the best term to use because honestly, the internal decapitations can occur lower than the atlas and occipital bone. They can occur anywhere along the neck, but you may see it referred to as such as an atlanto-occipital dislocation as well. And that's showing you right there how they would go about repairing that injury. You'll see they actually put plates and screws not only in the C-spine, but also on the occipital bone to hold all those pieces together with the hopes that that patient's going to heal properly and be able to get some integrity and quality of life back. But very, very serious injury. I've seen it on 2 different children who had really bad car wrecks, and they had that internal decapitation occur, and they had to completely isolate that. They had to basically put equipment all over the children to keep them still because if you ever had a 2-year-old, if you tell a 2-year-old to stay still in a hospital bed, not the easiest thing to do, but they had to be made to be very still so it would heal properly. So they actually had them basically restrained for weeks upon weeks while that injury was healing. A very serious injury and quite fascinating if you've never seen it before, but if you ever see that, that's going to be what we call internal decapitation or atlanto-occipital dislocation. And with that, we come to the end of the anatomy section of chapter 9. And we move forward to the positioning section very soon. So are there any questions on chapter 9 before we move to your worksheet I sent you to make sure you have the correct answers on your practice sheets? Any questions? All right, well, go ahead and take your quick break, guys. Let's come back at 12:47, and we'll make sure you have all the right answers on that sheet I sent you. Have that ready to go. See you in about 5 minutes. All right, everybody, let's go ahead and get back on board. We're gonna pull up that practice sheet that I sent you guys. Make sure you guys have all the right information. Get that pulled up myself here. All right, we have everybody back. Good, good. A few of you are still smiling. Got some brain cells left. All right, that's a good sign. Or is the food that good? All right, guys. So if you look at this, say again.
It's the coffee.
It's coffee. Yes, it blesses the soul. It touches the soul. I'm about to go get me another cup myself because, it was a night last night. My youngest daughter did not want to sleep last night, and that means the whole house didn't sleep last night. Anyway, let us move forward. So on this practice sheet right here, guys, you will notice there were certain pieces of anatomy that I did not cover up. If you do not see it covered up with a box, you don't need to know it. So this uncinate process, this posterior tubercle, don't need to know those, but everything else that's covered up by these boxes, you do need to make sure you know. Hang on a second, it's not letting me do what I want to do here. There we go. So remember, as you're studying, make those boxes disappear, help you see that anatomy, and quiz yourself and see where you're at. Make sure you know what kind of vertebrae you're looking at. So what kind of vertebrae is this, guys? If I just showed you a vertebrae, look just like that, what kind of vertebrae would that be?
The one on the bottom is that what you're looking at?
I'm sorry, yeah, the one on the bottom. Sorry.
Okay. That's a C-spine, right?
C-spine vertebrae, correct. Make sure you can tell the differences between the C and the T, specifically.
I do have a question on that, Mr. Donahue.
Yeah.
So, is there? I know, like on the T-spine, you have the superior and the inferior vertebral notches. That's what makes your intervertebral foramina. What about on the C-spine though? Do they have those notches, or what makes them on the C-spine?
A little less prominent, and the notches are present, Jonathan, but they're very difficult to see. They'd be underneath this articular process and underneath this articular process. So
Okay.
you might have to actually, they are there because obviously they have to form the intervertebral foramina, but because they're so obscured, we're not going to ask you to label those.
Gotcha.
Do definitely label them for the T-spine because you can see they're very prominent.
Right. Okay.
And speaking of T-spine, this would be your T-spine vertebrae. Remember those spinous processes point caudally downward. But all this anatomy that you see with the boxes, the ones you need to know, the ones that are not boxed, I'm not worried about you knowing those. Let's go down this first x-ray here. Now, this is obviously a lateral C-spine. Let's go ahead and name some of our anatomy. Make sure you have the right answers. So we start from the very top here. This is going to be the spinous process of C2 or the spinous process of the axis we're looking at right here. This arrow in the front, this is going to be the body of C4. 1, 2, 3, 4. The body of C4. This arrow here is pointing to this area where that circle is on that vertebrae. You remember they often look like circles. That's going to be the pedicle of C4. The pedicle of C4. Right here in this area is going to be one of those wonderful joints we talk so much about, that being the zygapophyseal joint. But specifically, what zygapophyseal joint is that? Well, let's count. 1, 2, 3, 4, 5, 6. This is the zygapophyseal joint of C5 and C6. zygapophyseal joint of C5 and C6. Now below that is referring to the anatomy that is forming the zygapophyseal joint. And I'll make sure that I specify this on your image review, what I'm looking for, whether it's joint or landmark. When we're talking about landmark here, this would be the inferior articular process of C6. And below that, it's the superior articular process of C7. So inferior articular process of C6, superior articular process of C7. LJ, why'd you bring that coffee right next to me, man? That smells good.
Needed
It's an
it.
emergency, man. I'm gonna give you some coffee. And by the way, once again, guys, I'm not worried about the left and rights on these, just that you label that corresponding anatomy. Now, you would have to put this as a right lateral C-spine, because we do see an R, but you don't have to tell me that it's the right zygapophyseal joint or the right superior articular process, so on and so forth. Just make sure you label the corresponding vertebrae for each of those pieces of anatomy. Once again, when you get to your image review, write your numbers on those vertebrae. It's going to help you, 1 through 7. And as far as identifying the atlas, axis, and vertebral prominence, atlas being the very top one, or C1, axis being C2, vertebral prominence down here with that protruding spinous process. Let's go down this one. This is going to be our AP axial C-spine. And by the way, when you talk about the AP C-spine, you must include the word axial, because we do put an angulation on that tube for the AP C-spine. So it's an AP axial C-spine. You do need to have that entire name on there for it to be correct. AP axial C-spine. Now, once again, if you remember, we're not ever going to see C2 and C3. This has been positioned correctly. So we know we're going to start with C3. So moving down this anatomy, this arrow is pointing to that little circular area. And anytime you see a circular area on a vertebrae, that's code for pedicle. So this is going to be the pedicle of C4. The pedicle of C4. This right here is going to be the body of C6. The body of C6. Right underneath that is the body of C7, or the body of the vertebral prominence. Make sure if that arrow is anywhere in that rectangular area, it's the body. If I'm pointing to that little spike in the middle, that's going to be the spinous process. They do overlap, they do superimpose, but make sure you can tell the difference between the two. Moving downward, we have the intervertebral disc space of C6 and C7. Intervertebral disc space of C6 and C7. By the way, I think I just misspoke, guys. Let me move back up. Tell you guys it's a coffee emergency. Let me go back up. Did I say this is the pedicle of C4 or C3?
C4.
Okay, I'm just making sure. I thought I said C3 for a second. Thank you. Thank you. It's a caffeine emergency, guys. I'm telling you. Intervertebral disc space of C6 and C7. All right, here, that's where I made a mistake. That's the intervertebral disc space of C7 and T1. I'm so sorry, because our first rib connects right here. This is T1. The intervertebral disc space of C7 and T1. And the body of C7, which is right here. So if I made a mistake on that, please fix it. I can't remember what I said. Actually, I had you teach today, LJ. I'm half cuckoo today.
Half cuckoo. We both need that coffee.
Can you say that one more time, Mr. Donahue?
I sure can. So this arrow right here is the body of C7. Right below is the intervertebral disc space of C7 and T1. Right below that is going to be the spinous process of T1.
Nice. Thanks. Need some coffee, huh? Me too. LJ, you got to go get that boy some coffee.
Yeah, so
Oh, I'm telling you, I'm like on 2 hours of sleep, guys. I apologize. On the right side here is going to be the right first rib. The right first rib. And then finally, this joint here would be the right SC joint. The right SC joint. All right, let's move on down. This will be your anatomy for a cervical vertebrae right here. Once again, the ones that do not have boxes on them, I don't need you to know those. Only the ones with boxes. And I 100% agree, coffee does save lives. It definitely saves my life. Amen to that. All right, so this would be an AP open mouth odontoid process, or AP open mouth dens view. So I'm shortened to just AP open mouth. But you can write AP open mouth if you choose to. I'll accept that. So the very first part of the anatomy is going to be, well, let me point to it. This first arrow is going to be the dens or the odontoid process of C2, or you can also write of the axis. So there's multiple names there, dens or odontoid process of C2 or the axis. This arrow right here is referring to the inferior articular process of C1 or the atlas. Inferior articular process of C1 or the atlas. Right below that would be the superior articular process of C2 or the axis. Superior articular process of C2 or the axis. Moving medially here, we are pointing at the bifid tip of C2. Bifid tip of C2 or the axis. And then finally on the left, we're referring to the joint. That's going to be the zygapophyseal joint of C1 and C2. Zygapophyseal joint of C1 and C2. All right. Let's move down right here. So this is going to be an AP T-spine and a lateral T-spine. AP and lateral. Starting from the top, we have the left first rib. Left first rib. Our next piece of anatomy being the left SC joint. Left SC joint. Once again, on the image review, I will designate if I'm looking for a joint, bone, landmark, or whatever. Right here we have the fifth intercostal space. The fifth intercostal space. Double checking myself. Yeah, that's the fifth. Fifth intercostal space. Let's count our T vertebrae. 1, 2, 3, 4, 5. This will be the intercostal disc space of T5 and T6. Intercostal disc space of T5 and T6. Right below that is the spinous process of T7. Spinous process of T7. Moving further down, this will be pointing to a rib, 12, 11, 10, 9. That is going to be the left ninth rib. And do make sure you still put your left versus rights on these with the ribs and the spaces as well. Left ninth rib. This right here is going to be the 12th left rib. This arrow is a little bit of an overlap to next chapter, but important to know regardless, it's going to be the transverse process of L1. Now, we have not done lumbar spine yet, but that is the transverse process of L1. If I had an arrow pointing to one of these little circles, for example, right here, this would be the pedicle of T11. The pedicle of T11. So make note that each of those little circles close to the ribs are going to be pedicles. They ask those as well. All right, let's look at our lateral T-spine. We have T12 down here. Remember the last vertebrae you can see. You can barely see the rib coming off. We're going to assume this is T12. So let's count backwards. 12, 11, 10, 9. This first anatomy we see here is the pedicle. The pedicle of T9. The pedicle of T9. These little connections you see right here, coming off the back of the body of the vertebrae, are the pedicles. Pedicle of T9. So this is going to be the intervertebral foramen T7 and T8. Intervertebral foramen of T7 and T8. This is going to be the intervertebral disc space of T6 and T7. Intervertebral disc space of T6 and T7. Movement superior is the body of T5. Body of T5. I think that is, yeah, that's all the ones labeled on that one.
Mr. Donahue, can you repeat the disc space? I didn't catch what vertebrae
Sure,
they
sure, sure. Let's count 12, 11, 10, 9, 8, 7. This is the intervertebral disc space of T6 and T7. T6 and T7.
Mr. Donahue, I have a question. Have you figured out if we're going to be able to write on the image review whenever we take our exam?
Not yet, but I'm working on that.
Okay.
Yeah, we'll figure something out for it. Any other questions on the images?
Yeah, Mr. Donahue, so looking at that lateral one, lateral T-spine, so it looks like, so you're only seeing a very small portion of T12. Is that right?
Correct.
Okay.
So like I said, Jonathan, for lateral T-spines, because there's a lot of variances on where that T12 is going to fall, depending on how the patient size is or where the centering was done by the tech. Always when it comes to labeling these on a lateral, you're going to look at that last vertebrae and assume that's 12 and work your way backwards.
Okay, no matter how, even if it's just that little portion of it you see, just assume that one's it. Okay, gotcha.
Yes. Any other questions on the images? All right, guys. Well, that will do it for your one and only class today. I'm sure you guys are so disappointed you don't have any other classes today, and I can see all over your faces. How sad. I mean, I can make up some physics if you like. I mean, I'm sure I can come up with something in my crazy mind about physics. No. Go ahead and enjoy the rest of your day, guys. So remember, they're saying good to meet you, LJ, by the way.
Hey, nice to meet you guys too.
LJ will be taking the positioning on Friday. Please let me know if there's any more questions or if something I said did not make sense today. I'll be glad to re-answer that for you because I know I've been half cuckoo today. I'm about to go get me another cup of coffee. But thank you guys for your attention. As always, have a wonderful afternoon, and we will see you guys on Friday. Take care and bye-bye.